this is one of the things that is it's just so vexing to all of us, because people say, well, which is the best one? Your new colleagues, new injecting colleagues want to know which one should I learn. So what we've done is to actually go over the whole literature of the comparison of the serotype A neurotoxins to try and tease out what might be science and what might be believable and truthful. You've seen our disclosures before. Now, there are a lot of worldwide available serotype A neurotoxins. I'm just going to confine my remarks to the Botox, Dysport, and Xeomin. But I know that you have Prosigna here. I know you have Botulift. And Puritox has had the phase 3 studies, but hasn't yet been approved in the United States. So could I trouble you to raise your hands? How many of you use Botox in your office? Could you put your hand up? Great. How many of you use Dysport? You can put the other arm up if you want. Okay. And how many of you use Xeomin? So I think it's actually really interesting. Another question, how many of you use more than one neurotoxin in your office? Show of hands. Okay. So that's really important, because I think that it means that you have open minds and that you are discerning the differences in the neurotoxins that are better for different areas in your patients' faces and bodies. When we look at how the neurotoxins are made, they're all botulinum toxin A. They're all from the Hall strain of Clostridium botulinum. There are some differences in how the product is actually, the dried product is put into the vial. And I think this is one of the things with Xeomin that we found in Canada, that we had a little bit of a problem initially with Xeomin because it didn't seem as strong as we thought it should be. And then we understood that the manufacturing process of Xeomin, actually there is neurotoxin not just in the bottom of the vial, but all around the vial. So what you have to do is put your saline in and invert the vial several times in order to be covered. And that's really made a huge difference. Has that been something that you've noticed in Brazil? Inverting the vial? Yes. Right. So there are lots of ways to compare the differences with botulinum toxin. And so let's look at some of those and see if they can be helpful to us. I feel humbled to be talking about diffusion and spread of effect here with both Ada and Doris and right next door to me here. So if I make a mistake, I know they'll fix me. So there are various studies comparing the diffusion or spread, and there seems to be a similarity, an equivalence with the Botox spread and Xeomin spread, and the Dysport seems, in some studies anyway, to spread a little bit more. The stability and storage. We've actually, I cry when I've realized how many vials I'd thrown out after I'd had them open only 4 hours. We found a vial in the back of the fridge that we'd had for a month. And of course, we injected it into Alistair. And it was actually very successful. It worked fine. So the nice thing about the incobotulinum is that the unopened vials can be stored at room temperature, as can the ANA and the ABO. But once they've been opened, they need to be refrigerated. So I think that the immunogenicity is an important point. And it's the foreign protein. So many of us remember the botulinum toxin that we had before 1997. And there was a huge incidence of cervical dystonia, getting patients with big doses getting IgG neutralizing antibodies. And it was as high as 50% in some series. And then Allergan took out 80% of the protein load, and it just went away as a problem. And so when you look at Xeomin, which is like the neurotoxin without the overcoat, without the complexing proteins, then at least theoretically there should be a zero incidence of a secondary non-response. And so, is this true? So we looked at quite a few studies with Marcus Naumann on a botulinum toxin, 16 studies, and we looked at 2,200 patients out of those studies with varying doses from small to large, and a total average of 0.49% seroconverted. So that's interesting. And it was higher numbers in the higher dose patients, cervical dystonia and hyperhidrosis and spasticity, and less in the glabella. So then what about with incobotulinum? What about with Xeomin? And so looking at the package insert, across pivotal trials in cervical dystonia, blepharospasm, and post-stroke spasticity, I was 1.1%. Well, you'd think it would be zero. But here's the rub. You can't really believe that, 1.1%, because the subjects were not botulinum toxin naive. And if you had eyes that spasm shut and the torsion and contortion that the dystonias give you, you would be treated as well. So I think that these numbers are spurious. And if you look at the US trials, 3.4%. But again, none of these people are botulinum toxin naive. Why do you have the overcoat? And the reason you have it is not really known. It might be to protect the 150 kilodalton active portion. It might be to shield the active portion from the soil when it's in the ground, waiting to infect your war wound. It might be that it's there to protect the 150 kilodaltons from the stomach acids. We just don't know. But we assume it gives stability. Abobotulinum toxin is a slightly different neurotoxin because it's quite heterogeneous. This is a really old reference because this is the only reference we could find showing what it's like in the bulk toxin. And we think that this actually may explain some of its diffusion characteristics. Now, this is the theory that you inject the botulinum toxin complex. So, in this talk, abo and onabotulinum, it dissociates. So now it's just the same as Xeomin, and then it binds to the receptor on the neuron or on the muscle. And so this is some research that was done from a scientist, Dr. Isila from Merz. And it shows that when at a more acid pH, the complex that they were studying hugs the active 150 kilodaltons, but as you make it more alkaline, it splits apart. And how long does that take? Well, they're looking at somewhere between 1 and 15 minutes. And so that's really an interesting study. We don't know if we need to see some more studies about this. We don't know if different neurotoxins have different rates of dissociation of their complex. And so I think it's a really interesting point. Now let's get into the therapeutics. All botulinum toxins work. This is why you're here. So many times you've done a study where they give you all these photographs and they say, will you please sort them out into before and after? And you can't, because there's just not enough difference between the before and the after to see a difference. And I can show you many pictures like that from studies. But botulinum toxin works, so you compare it in a study to placebo, it works. And that's what's so exciting about it. It works for everybody. And it's very true as well for incobotulinum toxin against placebo, and a lot of studies from all over the world are confirming that. So here is the problem we have. Is one neurotoxin better than another, or worse than another, or are they all the same? And what we need is studies that are actually designed the same way, The clinical trials have exactly the same inclusion and exclusion criteria, identical age and ethnicity of the subjects enrolled, identical quantities of severity, and they're using the same measuring scales. You just wouldn't believe when you look at the literature. It's a 4-point scale, it's a 5-point scale. There's no men, there's no individuals with any tone in their skin. There's no decent photographs. There's no patient-reported outcomes. So it's very hard, if you don't have the same ruler, to measure the equivalence of the effect of these trials. Now, Gerhard Sattler and Valerie Callender tried to do this in 2010, and they actually showed that incobotulinum was non-inferior to onabotulinum in the glabella at 24 weeks, which is fantastic, which is great. So the important trial differences in the previously performed trials are part of the problem, but a new problem has come along, and that is that the FDA has mandated a new definition of responders. What most people have had in the past is a 1-point improvement, which is a positive response. But now the FDA want there to be a 2-point improvement, and they want the subject and the investigator to see the same response, or they can't count that as a positive response. So what you see in this endpoint is that you're not going to know how many people had a 1-point response and how long that lasted. And that's actually a rather happy thing, a 1-point response. The patients are often very happy with that for quite a long time. And so I think that it's going to make it a lot more stringent. It'll certainly take out the placebo effect. It'll take out people seeing an effect in the placebo group. But it's going to cut it right down in terms of percentage of improvement, because the subjects are not allowed, and the investigator are not allowed to look at the previous photographs. So we tried doing a study, a phase 3 study for incobotulinum versus placebo in the glabella. And Hanke and Nairns did a similar study, in fact, an exactly similar study. And so we had exactly the same inclusion and exclusion criteria, dosage, randomization, study evaluations, and we were looking at a 1-point improvement. And we got this and statistics, and we got this wonderful improvement of 93% for the investigator and 86.5% for the subjects, which I think is amazing. But when you look at the new FDA way of counting things, you're probably going to see something like 20%. So what we were trying to do is to show that you can actually, in different centers in different countries, perform absolutely identical studies in large numbers of patients to try and sort this problem out. And you can see this is at 30 days, and you can see it's about 80% for onabotulinum. It's exactly the same for Dysport, and in fact, it's exactly the same for incobotulinum. So I think that these are studies that have not been made exactly the same, but they do show that there's tremendous similarity between the effects of all the neurotoxins. And this is what we were talking about, the longer partial effect, which a lot of our patients actually like because they don't like that frozen look. So apples and oranges are what we've got in the literature right now. And I think that we're going to see that it's not going to bother a lot of people. They're going to make their mind up anyway, for other reasons why they like a particular neurotoxin or a set of neurotoxins. But I think the whole point about this is so exciting to see that we've come this far. We're really in kindergarten with these neurotoxins. And we need to do some more sophisticated studies to show that it's going to be better for one thing or another. In the therapeutic literature, we certainly show non-inferiority with inco and onabotulinum. Now, a couple of studies, 20 units versus 30 units. 20 units is the standard registration dose in those two neurotoxins. And Morris Carpy and co-authors used 20 units of Botox and found it was equivalent to 30 units of incobotulinum toxin. And Prager and Rappel and co-workers did the opposite study, using 20 units of incobotulinum versus 30 units of Botox. And they found exactly the same results on both sides. So that was interesting. And I'm just coming back to that dose-ranging study. We found that in the female dose-ranging study, there really wasn't much difference between 20, 30 units, and that would actually confirm Morris-Carpy and Prager as well. I just wanted to come back to dose. The most important thing you should be thinking of, besides where is the tip of your needle, is what dose are you giving. And in my office, we actually charge by the units. We don't charge by the region, because then you can be more exact with what you're doing. But the larger the dose you are able to administer, the longer it will last. 20 units into the brow will last probably, 2.5 to 3 months. 40 units in the brow will last 4 months to 6 months. So it makes a huge difference. So we've sort of touched on all these different things. We don't know what the comparable doses are, except from these studies. And it would seem that with the Botox and with the Xeomin, that there is excellent comparability in the therapeutic group and most likely also in the cosmetic group. We just need to have some more studies and have people really think about dosage when they're injecting their patients rather than region. Now, here's a little thing that we've had happen. We've had about 10 disasters that we've been phoned about or emailed about, where the physician has had a number of different products on the tray, and each product actually has exactly the same syringe, so the local anesthetic, the neurotoxin, and the hyaluronidase, all in the same syringe. So now the physician's in a hurry. They're looking at the tray, and which one is which? They're not labeled. And so it's a disaster. We've had these people thinking that they're injecting local anesthetic in order to do filler injections, and now the whole face, 35 units of neurotoxin, paralyzed one side of the face, and that person is getting married in 2 weeks. So it's a disaster, and it's a preventable disaster. We prefer using the syringes that are hubless, because you get all the neurotoxin out of the vial that way, instead of losing some in the hub of the needle. So pick one that you're using. If you're having quite a few of you are using more than one neurotoxin in your office, pick a syringe. It doesn't have to be this one, but pick a different syringe for each neurotoxin. I think they're both fantastic syringes. So the 3 botulinum toxin A neurotoxins available on the North American market are indeed different from each other. And these differences are important, but they're also remarkably similar. And we suggest for most offices where, if you're running like we are in our office, you want to keep things simple so that you don't have any trip-ups. Getting to know one neurotoxin and using it most of the time so you really understand how to use it. Thank you very much for your attention.